Today in this lecture, we will talk about contribution of urea to hyperosmotic renal medullary interstitium and to a concentrated urine. So far we have discussed that a concentrated renal medulla, a hyperosmotic renal medulla is very important. And today we will study that there is a role of urea in keeping the medulla hyperosmotic. But why is the renal medulla hyperosmotic? Because it is one of the requirement for creating a concentrated urine. The other requirement or another factor for creating or excreting a concentrated urine is a release of antidiuretic hormone. Today we will study that how urea play its role in keeping this inner medullary region hyperosmotic. As the tubular filtration starts, there is little bit reabsorption of urea and water in the proximal tubule, and then the fluid starts moving in the descending limb, then the thin ascending limb, the thick ascending limb, the distal tubule, the cortical and the medullary collecting ducts. How urea play its role? Initially there is a little bit reabsorption of urea and water, which will not play a much role in keeping the medulla hyperosmotic. But when it comes to reabsorption of urea from the inner medullary ducts, inner medullary collecting ducts, urea can play a very big role, and it can contribute up to 50%, up to 50% in keeping the inner medulla hyperosmotic, especially when extremely concentrated urine is being formed. When extremely concentrated urine is being formed, then urea can contribute up to 50% or around 600 milliosmol to the hyperosmolarity of the inner medulla. The hyperosmolarity of the inner medulla is around 1200 to 1400. So in this 1200 to 1400 milliosmol, up to 600 milliosmol can come from urea at times when extremely concentrated urine is being formed. How it contributes this? How urea contributes to the hyperosmolarity of the inner medulla? The 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 thick the thin ascending limb of the loop of Henle, the thick ascending limb of the loop of Henle, the distal tubule, and the cortical ducts, they are impermeable to urea. They are impermeable to urea. Urea cannot be reabsorbed from these region. Normally, this region, the ascending thin limb of the loop of Henle and the ascending thick limb of the loop of Henle, they are impermeable to water. But when there is a release of antidiuretic hormone, in conditions where there is a deficiency of fluids in the body, there is release of antidiuretic hormone. This antidiuretic hormone, it causes reabsorption from the cortical collecting tubules, and distal tubules. But it also helps in the reabsorption of water from the medullary collecting tubules, medullary collecting ducts. So when water is being reabsorbed from these regions, urea remain in these tubules. Urea remains in these tubules, and water is reabsorbed. So the urea that remains in the distal tubule and the cortical collecting ducts, it becomes extremely concentrated. When it becomes extremely concentrated, this concentrated urea then move into the inner medullary ducts, Now in the inner medullary ducts, the highly concentrated urea, it starts getting reabsorbed from this region into the inner medulla. And this reabsorption of urea is with the help of urea transporter A1 and urea transporter A3. These are urea transporters, they are present here, and they help in the reabsorption of urea. When urea starts reabsorbing, it plays its role in hyperosmolarity. It makes this region hyperosmolar. It leads to increasing the osmolarity of the inner medulla. But how these urea transporters get activated? These urea transporters are activated with the help of antidiuretic hormone. So how urea plays its contribution, its role in keeping the hyperosmolarity of the medullary interstitium and a formation of concentrated urine is that urea is not initially reabsorbed here, and when antidiuretic hormone starts releasing, it starts helping in the reabsorption of water from the distal tubule, from the cortical ducts, and then this antidiuretic hormone also activates the urea transporters in the inner medullary ducts. So with the help of these things, urea that has become extremely concentrated, because water in the tubule has been reabsorbed in this region, in the distal tubule and the cortical ducts, but urea was not being reabsorbed. Now urea is also being reabsorbed. But the important thing is that the proportion of and urea water and urea that is reabsorbed from the inner medullary ducts into the medullary interstitium is equal. It is equal. So overall, the concentration of the urine is not affected, and concentrated urine is formed as well. So urea plays its role in keeping the inner medulla hyperosmotic, as well as helps in formation of concentrated urine. Now, this hyperosmotic inner medullary interstitium is not easily formed. There is a recycling of the urea. Urea is reabsorbed from the inner medullary duct, and then it is absorbed into these ducts again. That is the recycling of the urea. That is something which we will discuss in detail in the next lecture. Thanks a lot for watching the video.